Welcome. Good evening, everyone. Welcome to our webinar tonight on navigating patient medications. So this is part of our fall epilepsy series. So maybe you caught us at a different event in the past, and we are moving on. And I have a flyer at the end to share a little bit more about some of the upcoming events. My name is Aisha Akhtar. I'm the Vice President of Health Equity, Education, and Advocacy at the Epilepsy Foundation of Greater Chicago. If you are new to the foundation, welcome. I just wanted to give everyone a little bit of a background. We are a social service agency serving 44 counties in Illinois, and we provide case management, counseling, and support groups for all people living with epilepsy and their caregivers and families. We have programs for everyone and in hybrid form. So that's really amazing. So you can check us out on the website for more information. We also have a robust community and school seizure first aid training program as well as part of the Seizure Smart School Act from 2020. So just a little bit about us, and we will introduce our presenters here. So we have three speakers who are each going to share a little bit about the world of navigating patient medications. And there are so many different nuances to think about. So I'm going to have Dr. Wu first kind of level set with everyone and talk about medications in general and what people need to know. And then Dr. Habibi will be speaking a little bit more about anti-seizure meds. She's going to dial into that world of medications. And then we have Christie Edwards, who's going to take us back and talk a little bit more about how clinical trials come to be and how we are actually taking medications and how they land on our shelves. There's a very important element to clinical trials that sometimes people don't realize, that it can be the most altruistic thing you do when you are joining a trial to learn about how any kind of medication reacts to you. So that's a really important resource for patients in the future. So please feel free to type in any questions in the chat. I know this might be a difficult time. You might be cooking dinner with your family. But please feel free to put your questions in the chat and we will get to them towards the end. So without any further ado, I'm going to first plug the Community Needs Survey. So if you haven't seen this yet, please grab that QR code and we can post this later as well. But we are trying to learn the lay of the land. So if you'll indulge us and tell us how we're doing, we would love that. And then finally, my last slide before I turn it over. This is a little snapshot of the rest of the programs we have for this year. So please take a look, and we would love to see you at any of these events. So next month, for example, we have Women in Wellness, and then of course we have our annual education conference, the 15th year, which is really amazing. So we hope to see you at any one of those. So I'm going to turn it over now to Dr. Wu.
All right. Good evening, everyone. Thank you for the invitation, and I'm very excited to share some information with all of you. Hey, so in the next 20 minutes, I will talk about anti-seizure medications, general rules for their use and their side effects. Okay. So I'm not affiliated with any of the drug company, so the information I will share is purely based on the medical literature and my own clinical experience. So you can see here is the list of current available anti-seizure medications. There's about 20 different medication available today. Some of the older ones, you can see the phenytoin, phenobarbital, carbamazepine, valproic acid. This we considered as the first generation. And the second generation for medication include the gabapentin, lamotrigine, levetiracetam, oxcarbazepine, and then the even newer ones, lacosamide and rufinamide and clobazam, prampanel, most recent cenobamate. Those are considered as the third generation of medication. So how does medication works? Um, One of the main idea for why seizure occur is that there's an imbalance between excitation and inhibition of neurons. Glutamate is the brain's primary excitatory neurotransmitter. It acts like a gas pedal, making brain cells more active. On the other hand, GABA is the main inhibitory neurotransmitter. It acts like a brake, slowing down the brain activity. When there's too much glutamate or gas or not enough GABA or brake, the brain can become overactive and that may trigger a seizure. So the seizure medication work by restoring this balance. They might reduce the excitatory activity uh, uh, and enhance the inhibitory activity or a combination of the both. Um, Here shows a schematic map of the excitatory system, how excitatory system work. I won't bore you with all the details, but I do want to highlight a few key targets of the anti-seizure medication. As you already know, the glutamate is the main excitatory chemical, which is released when the sodium and calcium channel opens, so those ion goes in and trigger the release of the glutamate. So some of the anti-seizure medication work by blocking these ion channels to prevent the glutamate release. So the classic anti-seizure medications are the sodium channel blockers. You can see here the phenytoin, carbamazepine, and the newer ones like motrigine, lacosamide, and the oxcarbazepine, and even newer one as like carbazepine, all work on sodium channel blockers. And the calcium channel blockers are included the medicine, um, azoxystrobin, valproic acid, lamotrigine, um, uh, uh, and gabapentin and pregabalin. One of very common used medicine, levetiracetam or Keppra, it's attached to a protein in on this little bubble, pre-packed glutamate. It's called a synaptic vesicle protein 2A. It's a protein on the membrane of this little bubble, thought could prevent the release of a glutamate. After glutamate release, it binds to two receptors, NMDA and AMPTA receptors, to pass along the excitatory signals. These signals were blocked by the medication include felbamate and the topiramate and the perampanel or Fycompa, so the newer medication. In the inhibitory brake system, the main inhibitory chemical is GABA, is here. So we want more GABA to prevent seizures. Some medication reduce GABA breakdown, include the valproic acid and vigabatrin and tiagabine to prevent its recycled GABA. Others medicine to enhance the GABA receptor activity. It's to strengthen the brake system. That's include benzodiazepine, include lorazepam, clobazam, and midazolam, and also the other medication, felbamate, topiramate, zonisamide, and also phenobarbital. So also want to point out is vitamin B6 acts as a cofactor for the enzyme that's generate GABA. So you often see the patient with vitamin B deficiency lead to generate seizures. So your doctors might to replace the vitamin B6 to enhance the GABA effect. Some medication can have both GABAergic or work on reduced glutamate. That's include several medication, valproic acid, lamotrigine, zonisamide. So just to summarize, the sodium channel blockers are the phenytoin, carbamazepine, oxcarbazepine, and acylcarbazepine, lamotrigine, and the newer ones, lacosamide, etc. And the calcium channel blockers, the isosuccinimide, valproic acid, zonisamide, gabapentin, pregabalin, and works on the protein SV2A, that's the levetiracetam, and the second generation brivaracetam. And the blockage action of a glutamate receptor, as topiramate, perampanel, and felbamate. So the medicine works on the brake system, the reduced GABA breakdown, valproic acid, and mainly is used in the pediatric population, the vigabatrin and tiagabine, and the enhanced GABA receptor, as the benzodiazepines, phenobarbital, topiramate, and zonisamide, and supporting GABA generate the vitamin B6. The medicine works on both systems. So there's so many medication. The rule of choosing medicine is the correct choice of a seizure medication really requires accurate diagnosis of a seizure type or the syndrome. So this make the diagnosis clear is the most important, one of the most important factor to affect the medication option. So the right medicine can maximize the seizure control and minimize side effect. We know there's two big category of epilepsy. Generalized epilepsy is start from the both hemisphere and focal seizure from the one part of the brain. So for the primary generalized epilepsy, we want to choose some with the broader coverage. For example, levetiracetam, lamotrigine, valproic acid, isosuccinimide, zonisamide, because sodium channel blockers might worsening generalized epilepsy, particularly absence seizures. Okay, so avoid sodium channel blockers and gabapentin, pregabalin in the primary generalized epilepsy, particularly absence seizure. For the focal seizures, pretty much all the medicine can be used for focal seizures, either sodium blockers with the broad coverage. And the first line treatment are often levetiracetam, oxcarbazepine, lamotrigine, lacosamide, carbamazepine, etc. If at the beginning the seizure type is unclear, and certainly choose some medicine with the broader coverage and avoid the sodium channel blockers. Other factors also affect the physicians to choose medicine, right? Every patient is unique, right? For in the elderly population, the metabolism of the medicine might be slower, and the patient might have a kidney and a liver impairment. So we choose medicine, try to avoid the liver toxicity, and for the women of childbearing age, we want to choose some medicine considered safer to the fetus, include medicine lacosamide, oxcarbazepine, lamotrigine, levetiracetam, and avoid the medicine might cause any potential malformation. The most known one is the valproic acid. We also want to avoid phenobarbital and phenytoin because that might reduce the IQ of the offspring. And we also want to consider the side effect profile. And for example, the cognitive slowing, the medicine might have a less risk of cognitive slowing or include those few medication. And the medicine is known to cause more cognitive slowing are the phenobarbital, topiramate, valproic acid, carbamazepine, clobazam. And if the patient has a significant mood issues, we want to avoid levetiracetam because it might worsen the anxiety and depression. Other factors, weight medicine might cause weight gain are valproic acid, carbamazepine, and topiramate and zonisamide might cause weight loss. So they, based on the patient situation, so this might be our side effect, but another side could be our benefit. Patient might choose it because of the weight loss or weight gain. We also consider the drug-drug interactions. Medicine with more risk of drug interactions are through the enzyme inhibition or inducing, that include valproic acid, can increase the level of other medication by inhibit the liver enzyme. And on another hand, carbamazepine, phenytoin, phenobarbital might reduce the other medication level, blood level, by induce the liver enzyme. So valproic acid inhibit liver enzyme, and these three induce liver enzyme. And the rest of this few medicine has less potential of drug interaction. And we also considered other health conditions for the patient with severe heart disease. Lacosamide could potentially prolong or reduce the cardiac conduction, so prolonged PR interval. So avoid lacosamide in patient with severe heart disease. And the topiramate there's a risk of causing kidney stone. If the patient already have history, we should avoid. And patient have a liver disease, we will avoid valproic acid because this might cause liver toxicity, make the condition worse. And the topiramate might worsen the glaucoma, should avoid in those patients with glaucoma. So those here are just some example. There's a more factors might affect the physician to choose certain medication versus the other. So next few minutes, I want to just go over a few medications are commonly used, almost considered as a first line. Okay. Levetiracetam or Keppra. So based on the recent study, it used in almost 60% of newly diagnosed patients. Okay. Because it treats all type of seizure, it's a broad coverage medication and has relatively mild side effect compared to the older anti-seizure medications. And it's rarely cause any allergic reaction, fewer drug-drug interactions, and also less sedative effects and cognitive side effects. And it's safe across ages, including the women of childbearing age or during pregnancy. However, it might worsen the mood issues and also require dose adjustment in patients with kidney disease, particularly end-stage renal disease. Lamotrigine, again, is a broad coverage and has a relatively low side effects profile and causes less sedation and has minimal drug interaction. But it might reduce the effect of oral birth control pills. It should be cautious, be aware for the young woman, and safer during pregnancy or women of childbearing age. So it can be also used in the mood stabilization. So it will be perfect in the patient has epilepsy and also some mood issues. So the biggest concern is might cause severe allergic reaction. So needs a very slow titration, really take 2 or 3 months to get to a reasonable blood level. Carbamazepine is a sodium channel blockers. It's used for focal seizures, but it also can be used for mood stabilization and trigeminal neuralgia and neuropathy. Okay. However, it has quite a few side effects, can cause hypersensitivity, allergic reaction, might cause weight gain, and might reduce the blood salt levels or hyponatremia, might reduce certain blood cells and causes enzyme inducing. So it causes drug-drug interactions with a lot of medication. So oxcarbazepine is considered as a second generation of carbamazepine, and it's also used for focal seizures. It has lower risk of cognitive slowing and is better tolerated, has a fewer drug-drug interaction compared to the first generation's carbamazepine, and also safer in women of the childbearing age. The only side effect, even more than the carbamazepine, is a higher risk of lowering blood sodium level, hyponatremia. So that's we do need to monitor the sodium level after starting this medication. Next medicine I want to discuss is the lacosamide or Vimpat. It's a sodium channel blockers used for focal seizures. Has a lower risk of cognitive or mood-related issues. This is probably one of the best tolerated medication, and has minimal drug interaction. Also considered as a very clean drug. It's available in both IV and oral form, because some medicine only has a oral form, like lamotrigine. Right? So with both IV and the oral form can be used in the urgent situation, particularly in the prolonged seizure or need urgently loading medicine. It's safer in the women of childbearing age. So one of the concern is its reduced heart conduction and cautions the patient of severe heart condition. We already talked. Valproic acid, or other names, Depcode, Depkine, and is a broad coverage medicine, treat all type of seizures, and has multiple mechanism. It's quite effective. It's one of the older drugs, but very effective. So there's a lot of potential side effect, weight gain, significant drug-drug interaction, and more sedative than the other newer medications. Long-term use might cause tremors. Okay, there are several patients actually came in for concerning for Parkinson's disease, but actually they have tremors related to use of valproic acid, and might reduce the platelets in the blood, and it can cause liver toxicity and might cause birth defects, and the long-term use can cause hair loss. So we do need to monitor the blood. We check the blood periodically and monitor the liver function and also the blood cells. Now I want to switch the gear to rescue medicine. I don't know if any questions so far from audience.
Nope, not yet.
Great. All right, rescue medicine. So the rescue medicine is used to prevent seizures from becoming a medical emergency or status epilepticus. So it's we want to stop the ongoing seizures and also stop the seizure clusters. So clusters could be the several seizures in a short period of time is more frequent than their baseline seizure frequency. So cluster can be a different person to person. And the rescue medication allow patients and caregivers manage seizures outside the hospital and sometimes can avoid a ER visit. So this is the page I got from the Epilepsy Foundation. So there's current three FDA approved rescue medication. One is diazepam, is rectal gel or called Diastat. And there's two nasal spray. Nasilam is midazolam nasal spray, or Valtoco is a diazepam nasal spray. So you can see this one is mainly Diastat only mainly used in the children, okay, or little baby. And it's much easier to use nasal spray as a rescue medicine. So very easy use, just to push it in the nostril, and then can reduce the seizure duration and prevent the further seizures. There's a few other rescue medicine not FDA approved. That's the wafers and clonazepam wafers, and also the oral liquid lorazepam or diazepam. All right. So as the goal of medical treatment of epilepsy is simple, is no seizures, no side effect, as quick as possible. So this is really a team approach, involve you, your family, and your doctor. So with this team approach, 70% of patients can reach this goal. Always staying informed and following your treatment plan, and communicate with your doctors, and are the key to success of controlled seizures. With that, thank you for your attention, and that's all I want to talk.
Thank you, Dr. Wu. One quick question came up regarding ethosuximide. Did you want to touch on that?
Yeah, anti-seizure is our like showed here, is a calcium channel blockers. So this medicine only treat absence seizures. Okay, so only absence seizures. If the patient has multiple seizure type, absence seizure, myoclonus, or the mainly is grand mal seizure or tonic-clonic seizure, ethosuximide doesn't work.
Okay, thank you. And then one more question as a follow-up to you before we go to Dr. Habibi. Can an oral solution be used intravenously? Or are they kind of separate formulas?
No, they're separate.
Okay. Okay, thank you.
All right.
Wonderful. Let's dive in with Dr. Habibi.
Good evening, everyone. I'm trying to share my slides. Bear with me. Can everybody see my slides?
Yep.
So thank you, everyone, for joining us tonight. I'm a clinical pharmacist at University of Illinois in the neurology department. And there's going to be some overlap. It's difficult to talk about anti-seizure medications and not have some overlap with what Dr. was so nicely just covered. But I'm not going to stay on those sections that Dr. Wu has already. I'm just going to go through them much quicker. But we all know and have heard about brand versus generic names for medications. We're talking about anti-seizure medications and all other medications. So the brand drug that we are looking at or talking about is that original drug that is made or manufactured by the drug company. And they typically have the patent right, the right to market the drug to the consumers, to the market for a limited time. It varies a little bit depending on when they filed with the FDA. Usually is about 20 years that they have the right to just market that brand drug. But once that patent expires, then the generic companies can manufacture the medication and send it to the market, which is typically a much less expensive medication. Has the same active ingredient and must meet the similar efficacy and safety standards, similar to the brand medication. The inactive ingredients can differ. It may look different, but there might be several generic companies that are making the same generic drug. For epilepsy, it's always important that to remain on the same generic brand to avoid fluctuations in the medication level. So that's what we always advocate. But you may go to the pharmacy, and depending what pharmacy has on hand, they may switch the patients. And sometimes we do realize that switching from one generic to another may fluctuate some of these levels. So we always advocate, if possible, to stay on the same generic medication. Dr. Wu already talked about this. These are the first generation medications that were introduced to the market. And I'm sure you have seen these medications before, with the exception of primidone. All these other medications, as old as they are still being used frequently even today. One nice thing about the medications being this old is that we know a lot about them. We know about how efficacious they are, how they work, what are the possible side effects, what they're going to do. So we have a lot of information about the medications that have been in the market for so long. As Dr. Wu mentioned, ethosuximide is only used for treatment of absence seizures. The second generation medication that have come to the market, I put clobazam in 1984, but in reality, it was introduced to the market in the US in 2011. But we do have a lot of information about clobazam because before it was introduced to the United States, it was being used in Canada and Europe and other countries. So there is a lot of information at our studies trials about clobazam and what it does. And then the last group of medications, with the last one, cenobamate, that was introduced to the US market. As I said, Dr. Wu touched on selection, how we select the medications. So just briefly would mention it. As she mentioned, seizure type is very important, patient gender. She also touched on pregnancy issues. What are the plans for pregnancy? Age is also a factor. Children versus adult, young adult, and elderly. Children by size and weight use more medication compared to adults and elderly. As we age, our metabolism slows down and we use less medication. Other medical conditions that the patient has, other medication that the patient's taking, including over-the-counter medications. Sometimes we hear from our patients that they don't consider what they're buying over-the-counter as medications, but it's so important that you let us know that if you're using over-the-counter medication. And the reason is that some of them can actually do interact with your anti-seizure medications, either making them less effective or causing toxicity. Some drugs can make seizures worse. Again, another good reason to let your doctor know that what other medication you may be taking or want to use to make sure it's not the medication can lower seizure, what is called lowering seizure threshold, or increasing the risk of breakthrough seizures. And then some medications have similar side effects. And one of the most bothersome side effects of these anti-seizure medications have a tendency to make the patient tired. Sometimes they can cause dizziness. So those type of side effects. So if you're on multiple medications that have similar side effects, then obviously there's a risk of for having experiencing the same adverse events, even if you're at the lower dose of your anti-seizure medication. So it's very important that you share all that information when you come to the clinic. The other thing that is very, very important, if you experience an allergic reaction to a medication, then we know which other medication we need to avoid. For example, if the patient has had an allergic reaction to phenytoin, then we know which other anti-seizure medications we need to avoid and not be prescribed so that we avoid a second more severe allergic reaction. What other medications has ever been tried in the past and why were discontinued? A patient didn't tolerate it. At what dose the patient didn't tolerate it? Didn't control the seizures, at what dose and at what level it didn't control the seizures. So those are all important information when we are selecting or switching the patient to another anti-seizure medication. Also keeping in mind the properties of the medication itself. Does it work for one type of seizure or multiple type of epilepsies? As Dr. Wu mentioned, is it broader spectrum or narrow spectrum medication? How long does it last, which is a technical term that is called half-life of the medication, which basically what that means is the time that it takes for 50% of the medication to be eliminated from the body. For that reason, is the medication taken once a day? Is it going to last that long, or does it need to be taken twice a day or more frequently? So medications that have a long half-life, typically are designed to be taken once a day. Medications that have short half-lives, and one example of a medication with short half-life is this very popular medication, Keppra, has a short half-life, that need to be taken twice, or other medications that need to be taken more frequently. It is important because sometimes I hear from our patients that they're on a medication as a short half-life, doesn't last that long. And we see them and they say, well, I take my medication only once a day. And when we ask, well, why do you take your medication only once a day? The response is that, well, I don't think I need it more frequently. And I always use the example of eating food during the day. So you can have your breakfast and say, I'm good, I'm not going to have lunch. And dinner is the same thing with medications. They don't last, especially if they have short half-lives. By the time the noon or afternoon comes, most of that medication is gone and puts the patient at risk of having breakthrough seizures. Different formulation is another tool that basically we use when we're selecting a medication. Is it immediate release, or is it an extended release medication? We prefer extended release formulations, which basically means that the medication, the way it's been made, is going to get slowly released in the system, versus a medication that is immediate release and quickly gets released in the system, in the body. So the reason that sort of we prefer, if a medication has the extended release formulation available, we prefer that. It basically helps the patient to reach that maximum level in the blood, or what the other term that is called is peak level, gradually, and it lasts longer. And that helps with some of the bothersome side effects of these medications, that when this high level, this maximum level is reached quicker, that's when the patients can experience, sedation, dizziness, some of the side effects that is bothersome. And then the extended release formulation sort of help to avoid those, so we prefer those. And then if that's not available, sometimes patients come and say, as soon as I take my medication, 2 hours or so after that, I have these symptoms, which basically tells us, yeah, this happens when the medication is reaching its maximum level or peak level. If the medication is not available in an extended release formulation, one thing that we always tell our patients, take your medication with food, because food does the same thing. It slows the absorption of the medication, just it slows it down. It doesn't prevent how much of the drug is absorbed. The full drug is going to get absorbed, but it slows that rate and sometimes can help with those type of side effects. These medications, because of some of these possible side effects that Dr. Wu was mentioning, are usually started with the titration. I'm sure if you're taking these medications, you're familiar with it, that your physician gives you a titration schedule, tells you how to start this medication and slowly increase the dose. Some medications already have titration kits that you can go to a pharmacy and pick up a kit, and the kit tells you how to take this medication slowly every week. And if not, then as I said, you get a titration schedule as how to increase that dose. It's very important because, as I said, it minimizes the risk of potential side effects. For some of this medication, it minimizes the risk of having an allergic reaction. So it's important to follow that titration schedule. If you are discontinuing a medication, it's very important that we slowly decrease the dose and discontinue the medication. Again, this is to avoid the risk of worsening the seizures for patients. So especially if the patient has been on the medication for a long time, that we slowly, gradually take the medication away. Dr. Wu also touched on this. We're always looking at issues with possible drug-drug interaction, basically enhancing or increasing the metabolism of other drugs, or making other drugs becoming less effective if they're metabolized quicker, or inhibit the metabolism of other drugs, causing risk of toxicity. And the same issue as I initially mentioned, other drugs enhancing or inhibiting the metabolism of the anti-seizures, if are enhancing its metabolism, making them less effective, or if they are inhibiting their elimination, increasing the risk of or potential for toxicity with anti-seizure medication. So we're always looking at those issues. So I'm going to sort of switch a little bit here and talk about medication formularies, which basically is a list of medications that are covered by the insurance health plan. They specify which medication is covered, which one excluded, brand versus generic, and the cost. Obviously, brand drugs are always have higher cost. One term that we come across is this medication tiers, and medications are divided typically into different tiers and based on their cost and clinic use from 1 to 4. And the cost of with tier 1 would be less, and the higher cost would be with tier 4. You can always look up the status of your medication in the formulary, either by checking by category. For example, if you go under in the formulary, if you look at the anti-seizure medication and you're wondering if lamotrigine is covered or not covered, you can always look it that way. Or you can just check the drug in the formulary index, and it will tell you if the plan is covering this medication or not, or what are the limitations with the coverage of that medication. Some of the abbreviations that you may come across, you might be already familiar with these terms. One of them, very common one, is PA, or prior authorization is required. That the health insurance is basically wants the doctor's office or the clinic to submit for prior approval, getting permission to use these medications. We do get these sometimes for anti-seizure medications, and we need to submit a request of prior authorization to get the approval to use as a specific medication. Another term that we come across is this QL, or quantity limit, and that the health plan has a restriction on the amount of medication that can be obtained within a specific time period. Some of the other terms, LA, or limited access, that medications are not fully covered or required additional step for coverage. ED, or excluded drugs. Step therapy is another term that we come across frequently. And it's not only for anti-seizure medications, it's for other classes of medication as well, that the health plan asks or requires that a different form, a generic or lower cost medication options are tried first. And they want that to be tried first before sort of they allow another sort of medication from so it's a step therapy to be used. And we usually, get this in the letter that we receive, that you have to use medication A or B or C, 2 of this category before you can use the medication that you're requesting. There are other terms in formularies, abbreviation. This is not reimbursed, not preferred, or not formulary. We see those terms, obviously, we change here. It's not very common with anti-seizure medications just because of the nature of epilepsy. But again, we do come once in a while. We do come across those terms for anti-seizure medications. We do submit for, as I said, for anti-seizure medications if the health plan requires a PA to be submitted. Once in a while, we do get a denial that this has been denied for one reason or the other. I have done this often enough that I know what needs to be done. And then we submit an appeal the health plan denial. And I will tell you that 99% of the time we get the medication approved. And then addressing the quantity limit, this is another common thing that we may come across, that there is a limit of number of medication that the health plan allows us to use. Sometimes we do come across this if we exceed the number of tablets that the health plan allows us to use per month. If we are, for example, we are prescribing lamotrigine and we are using lower dosage form, and the patient ends up to be on multiple tablets a month. Or I have come across this with lacosamide. If, for example, we're using 100 milligram tablets and the patient ends up to be using more tablets per month, and the health plan wants you to use only, 60, as of I'm thinking about 60 tablets a month. So we do come across this, but there's always ways around it to fix it, and we'll work on it. And as I said, 99% of the time we get it fixed. That was my last slide, and I'm happy to answer any questions.
Amazing. Thank you. Both of you gave so much information, so informative. There are quite a few follow-up questions. I don't know if you want to answer them in the chat or we can let Christy go and then we can answer them later. What would you, or you can answer them in the chat while Christy starts.
Sure.
Whatever you would like. I know, Dr. Wu, there's a few questions that are for you, and there's one on midazolam that came up. So maybe Christy, why don't you go ahead and start? You can bring us back and kind of zoom out and talk about clinical trials. And then if Dr. Wu and Dr. Habibi can go in the chat and take a look at those, then there will probably be follow-up questions. So why don't we do that?
Okay.
Thank you. Thank you.
So I feel like my slides will be, pretty easy, very chill, and this will be more of a conversation. So again, my name is Christie Edwards, and I work for Inside Edge Consulting Group. It is a minority-owned consulting firm that is looking to be the most valued partner in reducing health disparities in medically underserved communities. And I'm going to share the work that I do, but more from the lens of me working in the community, just so you can kind of get a snapshot of the work that I do. So with us being a consulting firm, we do have clients. One of our clients is Johnson & Johnson, and that is actually the company that I do the clinical trial or medical research education on behalf of. So my role or my title, it is Community Clinical Navigator. So the clinical trial space is definitely a new road for me. I have almost about 20 years of experience working in hospital systems here in Chicago. And so with my background in public health and a focus in community health, going this route in terms of educating and helping to reduce health disparities from a clinical trial lens is definitely new for me. But I go into these medically underserved communities, which we are looking to, medically underserved, it encompasses everyone. But some of the communities that we're really highlighting are African American, Latinx communities, Asian communities, Native American communities, older adults or mature adults, LGBTQ plus, and veterans. And so my sole job is to just create awareness and to allow people in the community to let them know that clinical trials are an untapped resource and can be used to either save a life or to improve the quality of life. So I mentioned I'm not recruiting. This is purely just educational. The slides that I use going into community, they are written in at an educational level about fifth grade or so, because we want to make sure that the information is palatable for all communities. There is a pre and a post survey that we do ask of community members, because with us going into communities, our role is boots on the ground. We really want to get an understanding of what community understands around clinical trials, where are some of the knowledge gaps, and through that information, we are able to figure out how we can better improve the program that we facilitate out in these communities. One thing that's very surprising, but probably not surprising for you all, is that when we are going into these medically underserved communities, a lot of people do not understand what clinical trials are, or actually that word is very scary for them. And so what we do is we go in and we empower them with the information so that they can be empowered to make decisions around their health. A lot of times if communities or if people don't understand, they fear. And so through the education and bringing awareness, we like to take that really scary word and kind of bring it down to a position where people are understanding what clinical trials are or medical research. I'm also learning that some of our community members feel that clinical trials is a little bit of an aggressive word. And so as a team, we're looking at other ways how we can perhaps maybe use medical research as a way of saying the same thing, but maybe it doesn't sound as scary. So this is a screen that I don't share this specific to our community folks, but we want to let people know that clinical trials is not just, it's not invasive all the time. It can also just include testing out products, just testing out simple treatments like Benadryl or Tylenol, or even birth control pills. Ultimately, clinical trials is to see if treatments are going to be effective and safe for people that are taking them. And so the reason why we are wanting to educate is because a lot of these medically underserved communities are not accessing or able to access clinical trials. And we're trying to understand, where is the gap? Is it because they don't know about these clinical trials? Is it because their doctors are not talking to them? Is it because it's not accessible to them? We're trying to figure out where those gaps are. And we really want to make clinical trials or medical research very accessible to the communities that we are going into and educating around. So we do like to highlight why it's important for diverse groups to participate in clinical trials. We want to make sure that, with clinical trials being this resource to people that can help improve health outcomes, we want to make sure that it's accessible to everyone. And so we want to make sure that people understand that, we want to ensure that the treatments work for everyone. We want to ensure that it's also, in their participating in clinical trials, it's also addressing health disparities. And then also we like to highlight and let them know that participating in medical research, it helps to improve the efficacy and safety of treatments that are available out on the market. Us bringing this education does help to dismantle, breaking down that big word of clinical trials, and it brings it down to a position where it allows them to feel a little bit, feeling more trusting in medicine because it's not so big now that they understand what clinical trials is. So we break down everything. What are clinical trials? What to look for? Who are the people, places, and things behind the scenes to ensure that clinical trials or medical research is done safely and effectively? We also let them know that in participating in clinical trials, that it is a way of advancing personalized medicine. And then it's also, again, ensuring that access to these treatments is equitable for everyone. So in one of the, it's not on this particular slide, but I did pull some data from the FDA drug trials snapshot. We show them a graph. We show them on one side of the graph, there is data on what like the approximate census of, ethnic groups that make up the US population. And then next to that graph, we have a graph of those same population groups participating in clinical trials. And of course, data does not lie. Data always tells a story. So showing community that, hey, on one side, we're showing and demonstrating this is the approximate percentage of people that make up the US Census. And then on this side is the approximate percentage of those same communities or ethnic groups that are participating in clinical trials or not participating. And when they see that, it basically, it does give them some food for thought, because ideally we would like to have all of those graphs kind of equal and not, groups on the lower end. And so we let them see that data tells a story. And I also share with them too that, when diverse groups are not participating in as testing treatments, our goal is to ensure that treatments are available to everyone and that it's accessible to everyone and it's not just specific to one group, because we want to make sure that all treatments are safe and effective for all diverse populations. So my call to action, just, and this is a pretty brief slide deck, but my call to action is really, sharing with you all the work that I do. It's here in Chicago, and I also am doing this work in Detroit. The need is great. A lot of people are starting to come around and starting to learn more about how clinical trials can be used. When I am educating folks around clinical trials, I use my lived experience. Having my son participate in clinical trials, the information that we do share out in community, because we want to give them just a very baseline understanding of what to look for, what to expect, if they decide to participate, what's an informed consent. is there an opportunity for them to opt out? If they opt out, what does that mean for them? Letting them know that some sites offer flexibility in scheduling, letting them know that some sites will actually pay for, participation in clinical trials, letting them know that some sites will even be flexible and, provide transportation for them, and to just ask. I think the most important thing is just bringing this information into communities so that they can feel empowered to make decisions around their health. But again, the slide deck that we share is condition agnostic, so it's just general information. It's not focused on anything in particular. But I do share my story about my son who had asthma at a young age, and clinical trials, our participating in clinical trials was actually a really great way for us to get access to new treatments that actually worked for him. And he just made 24 a couple weeks ago. And since the clinical trial, he was about 7 at that time. Since participating, he has had no issues. So having that information to community and sharing my story and my lived experience and how I was also very hesitant with research has helped to be a little bit more relatable. But, I'm looking for long-term partnerships with people in the community, which includes faith-based groups, community-based organizations, FQHCs, LGBTQ plus groups, older adults, or even veteran groups. So that is my work that I'm doing around clinical trials. And then if you all are interested in connecting with me, here's my QR code with my email. So if anyone has any questions, I'd be more than happy to answer them, and just let me know.
Yeah, thank you, Christy. One thing that someone just mentioned, which I'm sure happens quite often, is what happens when someone doesn't qualify for a trial? Like, are there other alternatives? Are there other options for them to be able to get involved in some sort of medical research?
Yes, and I'm going to actually close this out. So something that I do share with community too is, it's just like a job. When you are interviewing for a job, you want to make sure that this job is right for you. You know the qualifications. Sometimes you get the job and sometimes you don't. Same thing with clinical trials. But I do like to let people know that just because you're not accepted into the trial, it does not mean anything. You're still able to walk away with some really important information and numbers around your health. So that's another thing that people think too. It's like, oh, well, I was able to, I went through the screening process, but, through the screening process, they decided that I wasn't a good candidate.
Hmm.
That might, and, to some people, you may feel some kind of way, but you're actually walking away empowered, having some information around your health, whether that's, your blood pressure, your weight, that's information that you're able to walk away with.
That's true.
So
Still
there
valuable.
are, again, my education, it ends with the education, but we are able to guide them. I think we're just trying to figure out where are the gaps and why is this information not accessible to everyone? Some doctors have access to clinical trials
Hmm.
where others don't. So we've been really thinking innovatively on ways to make it so it's not so challenging.
Right. Now, is there like a general repository where people can go? I mean, I know there's clinicaltrials.gov. Is that the best place where anyone should start?
They can, but that website is very wonky and it can be very overwhelming for some people, especially if medical language is something that's not new for you. I mean, that is new for you. So
Hmm.
that's another thing that we're trying to work on. If there's maybe a more like nationwide clinical trials, access that, that will provide people with information that's not as intimidating. Because again, talking about research, it is very intimidating for a
Sure.
lot of people in the community, especially when you think about, historically how some minority groups have been affected with research.
Right.
That's a barrier that we are also having to break through around this education.
Right. Wonderful. Thank you. If anyone would like to ask any follow-up questions, you're welcome to come off mute or type in the chat. What questions should patients and families ask doctors if they're unsure about their medication? Because a lot of times there is that barrier, whether it's the health literacy, medical literacy, but what are some of the best practices that our families can be putting in place? Like, as providers, what do you want to be asked?
As a provider, I feel like we are at least for me, I'm prepared for answer any questions, particularly when the diagnosis of seizures are new. This can be very overwhelming, right? They are previously healthy, and suddenly with this condition, they have to take medicine every day. So, any medication, just to openly communicate with your provider. So we are here. That's the reason we are here to provide information and treatment.
Wonderful. Thank you.
I actually have one question to Dr. Habibi. So you talk about the quantity limitation. For me, is some of my patients came in because they run out of medicine ahead of 1 month and have trouble to and couldn't get medicine for a certain time. So as a provider, we always was trained to write 30 days supply. Is any other way you recommend to avoid this? Let's go ahead.
Well, that's a great question, Dr. Wu. The issue is those rules are set by the health plan providers. The health insurance company sets those rules. Typically, you can write for a 90-day supply for some medications. So that's one way of, so some insurance health providers allow you, I may not apply to controlled medications because sometimes they don't want, again, it depends on which insurance company the patient has. May not apply to controlled medication like clonazepam or clobazam that they want to dispense a 30-day supply. But with other medication, you have the option of asking for 90-day supply. But again, the pharmacy is going to dispense exactly 1 month supply is going to multiply it by 30 by 3 months. It's very important and that you initially, if you are dealing with a medication of lamotrigine, you may not come across these pharmacies know that you have to do the titration. Insurance companies know, but with some other medications, we all have to be very careful that this tablet size that you're using is very important. So, for example, sometimes what I do, I use that larger tablet and I tell the patient to cut it, so that I don't come across, and a good example would be lacosamide, that I know that I have to use less, or for this patient, we have to use less because of the sensitivity patient has, but I know that I'm going to run into whatever issues. So that the insurance company wants me to do this or that. So sometimes I do that. I use a larger size that the insurance company wants me to use, get 30-day supply, but I'm not going to go to that dose, and I have the patient cut the dose and cut the tablets. We do that all the time. It's unfortunate. I don't know if I'm making it clear, but we do that all the time so that the patient has the quantity that they need. But the insurance company is only dispensing 30 days. I've done this with multiple medications. I use the larger tablet, but it takes me time because I have to sit down and write the titration schedule and explain to the patient and make sure that the patient is on board and can follow my titration. But that's one way around it.
Can I write
Christie,
35 days of supply and then patient get refill every 30 days?
No,
Okay.
no, unfortunately. Sometimes you can write for higher, as I said, for higher doses, which sometimes I have seen that happen. And then, as I said, the patient gets, or you can say TID rather than you want your patient to take BID, but you write, for example, for Keppra TID, and the patient would get more tablets, and you bypass that. One risk of doing that, you have to make sure that your patient is well educated and there is no risk of toxicity and overdosing. So if you have a patient who you feel comfortable that they're able to do that, sometimes I have seen that happen, that the medication is twice a day and the physician writes for 3 times a day and tells the patient, this is what I'm asking you to do because I need to do this. But education for those patients plays a significant role to make sure that the patient is completely understanding what you're trying to do.
right. But I have a follow-up question. You talked about the half-life. So if we're able to break a pill in half, how does that impact the half-life? Or is it just for specific pills, specific circumstances?
Well, that's a great question, Aisha. Breaking the tablet is not going to affect the medication half-life. You're not supposed to break the extended release formulations because that is going to destroy the way the medication is packaged, and the medication is not going to be extended release anymore. So we don't do that.
Okay.
But if a lacosamide is not extended release, I ask our patients, they get a pill box from Walgreens, is a few dollars, and they cut the tablet in half.
Perfect.
I have done that. Multiple times.
Perfect.
But it won't know the medication. Those things don't affect the half-life of the drug.
Perfect. Christy, you had your hand up. Yeah, okay.
Yes, I hope this is well, I figure my father's epileptic, so I'm hoping that I can just ask a question. So, my father has been on epileptic or epilepsy medication for over, I want to say 4 decades now. And so with that, it has really done a number on his kidneys. And so I'm just curious, as providers, what kind of advice can you give to patients, letting them know? I mean, of course, benefits outweigh the cost. Eventually, his quality of life, he's been able to, live a pretty much seizure-free life. But now on the back end, we have this chronic kidney disease that has really impacted his life. Um, are there any recommendations that you have in terms of medications that may not necessarily create such havoc on his kidneys? Or what kind of advice would you offer to patients that may be a little nervous about those side effects over time?
I can go first. So, one dose of a medicine doesn't fit uh, always, right? If your dad has taken medicine, the same dose for many, many years, certainly need to check the levels and some of the common used medicine like levetiracetam, we do adjust the dose based on the kidney function. And you can always check the capra level and to see if it's too high or too low and adjust the dose based on the level. Um, Several medications do require those adjustment based on the age and the kidney function. I don't know if Dr. Habibi, any.
No, you're completely correct. So our medications use the kidney to leave the body, but they don't do anything. Sometimes I hear that from our patients, to the kidney. They just use the kidney as a vessel to leave. For example, Keppra, as Dr. Wu was mentioning, it literally uses the kidney to be medications like food. They have to get excreted from the body. So Keppra uses the kidney, and you just basically you lose it in your urine. Doesn't do anything to kidney, it's just using the kidney to be excreted. So, and as Dr. Wu mentioned, there are medications that we know, like Keppra, that uses the kidney to leave the body. So we always, for those patients, especially as we get older, we know what happens to our kidneys. It happens to all of us as we age. It's very important, especially if you have an elderly patient, or that your dad is elderly, that I'm sure they're checking the renal function, and Dr. Ward mentioned, and this dose is specifically to that renal function, and see how much this patient needs. The patient that has a lower renal function obviously will need so much less than somebody who has a normal renal function or kidney function. Christie, is that what you're asking, Christie? Is that what you were referring to?
Yeah, I was just curious to hear what you all had to say. We don't know if we were under the impression he's a veteran, so we were under the impression it was because of the medication.
What I know, Christie, and Dr. Wu can obviously, I'm
Okay.
sure, can add to this. None of the medications that we know and we have had for seizure control of seizures, they don't do anything, they don't harm the kidney. They just use the kidney like anything else that we eat. That they have to get away, they have either they get metabolism in the liver, or they use the kidney to leave the body. That's what those medications do. They don't go, there are medications out there that can harm the kidney and stuff like that. As far as I know, none of our seizure medications has that potential. They just use the kidney.
Okay. Thank you.
You're welcome.
Would you put your patients on a regular cadence for blood tests, for example, to monitor things like kidney or hypertension, et cetera? Like, is there anything that you would recommend to get their blood levels checked on a periodic basis?
So for me, I check the blood not very often unless either seizures are not controlled or have experienced side effects, or because either they have a kidney function declining that might affect the level of the medication. Or there's some other medication introduced that might interact with the seizure medication. In those situations, I do check. If the patient is stable on medicine for many years, I don't regularly check. Or obviously, any significant weight loss, weight gain, I check as well.
Okay.
I just saw a question. I agree with Dr. Wu. I mean, if somebody is stable, we don't routinely check. If it's Keppra and we are dosing based on, we know the patient has, diminution of function, obviously, when we are dosing the patient, we always check that. But not, as Dr. Wu mentioned, somebody is stable on medication, we do routine check. But I just saw a very good question in the chat about generic versus brand medications. And we get that question all the time. And I think that's a great question. That they're saying, what are the differences about generic and brand medication? So as far as when it comes to levels. So majority of our seizure medications, majority of them, other than a handful, maybe Aptium or Xcopri, majority of the rest of our medications are now available in the generic form. And most likely, if the medication is available in the generic form, what we get approved, what the patient gets approved is for the generic form. And it's, that we have no control over this unless the patient has had a reaction to the generic form, and we can use that and say, yeah, this patient cannot because of this reaction that they have had. So majority of our patients, and I don't know what Dr. Wu's experience is are on generic medication. So we are very comfortable with using generic anti-seizure medications, and the people who are here should be comfortable using generic formulations of these medications. This is what happens. So there are obviously some differences. What happens is the patient starts on this. That's what we want. We would prefer that the patient stays on the same generic company as much as possible. Because what happens is the patient is on this dose, they may have a level, the seizures are controlled, and we know this is a good dose, the patient's seizures are controlled. This is when we need to keep the patient. The issue happens when the patient gets switched around from one generic form. And it doesn't happen in every patient, but some patients are more sensitive from one generic form to another generic form. And they may have fluctuations in their levels, and either may experience side effects or breakthrough seizures. So my experience has been that majority of our patients on generic formulations, they do perfectly fine. And the goal is that when you go to pharmacy, if possible, that you ask that you stay on the same generic formulation, and it's perfectly fine. And I don't know what Dr. Wu's experience has been.
Completely agree.
Thank you. We are just about at time, and I know looks like Dr. Wu, you're still at the clinic. So, and Dr. Habibi, thank you so much. And Christie, thank you for being here, and thank you for sharing the story about your father as well. I hope everyone got something out of this amazing, informative webinar. Thank you to our presenters. As I mentioned at the beginning, this has been recorded, so this will live on our YouTube page. So thank you for each of you, for your contribution to the community, and I wish you all a good night and see you at the next event.
Thank you so much.
Thank you.
Bye,
Thank
everyone.
you. Bye.